diabetes. Others call it a disease for the rich. Now, prevalence of diabetes in Uganda is on the rise, and according to the 2016 Health Organization Global Report on Diabetes, the prevalence of diabetes and risk of related factors has been increasing steadily, with the numbers now at 2.7% for males and 3% for females.
The sad reality, however, is that Uganda's healthcare system is unable to cope with the increasing numbers, since the healthcare system is still overburdened with infectious diseases, maternal and child health problems. Now, the healthcare system is also not yet adequately prepared for diabetes prevention and management. This is why local scientists are now coming up with innovative ways in the management of this particular disease. So in studios to have that conversation is Dr. Francis Xavier Kasuja. He is part of the Makerere University School of Public Health, and we'll be having that real conversation with him right here. Thank you so much for coming on board.
Thank you.
Rita.
Now let's start with why the increase in the number of people getting diabetes in our country.
Yeah, so as many of you may be aware, diabetes has been quite rare in the past in our communities, but of recent we've seen the numbers rising very high. Current evidence shows that up to 1.2% of adults in Uganda have diabetes. And actually that's in Uganda we're lucky, the numbers are still that low. In the region, the numbers are in some places twice as high, in other places even 3 times as high. And we believe as researchers that the fact that this condition was rare before and is rising, it's related to lifestyle problems. So our lifestyles have changed. So in the past, we used to live a very active lifestyle. We used to eat healthy, vegetables, fruits, and because of the level of physical activity, we used to burn most of the fats that we could potentially build from that food. Currently, this is not happening. Most of us, for example, are traveling to our places of work today in our cars. In the past, we would either ride or walk to work, but not walk to work in the political sense, but in the sense that you had to put in that effort to walk maybe for 30 minutes, 45 minutes, 1 hour to get to work, and you'd burn the calories. This is not happening today. And most of us have office work instead of the traditional field work, or should I say farming, that we used to do. With all that, we're actually storing most of the energy that we derive from the food we eat, and that is by piling on that the fats, we're actually increasing our risk of diabetes. So in summary, diabetes is mainly a lifestyle disease. So
mainly
a lifestyle disease.
But what percentage of that is genetic?
I can't really say for sure about the percentages, but yes, there is ample evidence that black Africans and of course black Americans are predisposed to diabetes. So we have a higher risk of developing diabetes compared to, say, white people, Caucasians. So that is true.
Any
However,
science behind that to explain that?
Well, the science is a little bit deep, but it has to do with the clustering of genes that increase our risk and increase our what we call insulin resistance, meaning that we are producing insulin, which is the hormone that helps regulate blood sugar, in higher quantities, but even at those higher quantities, the insulin is not able to reduce blood sugar to the levels that we need in order for it to be normal.
Right.
Yeah.
You mentioned something about activity and how maybe we're now sitting more than we should have, or we used to. That means there are things we could do to prevent this.
Exactly.
So let's talk about the innovative ways, because if we say that right now our healthcare system is burdened by the numbers and they're unable to cope with the numbers, the rising numbers, what can someone who maybe is trying to avoid diabetes do, and also someone who has diabetes, how can they be able to do a few things at home to keep this at bay?
Yeah, so this is a very interesting topic. So in the past, our approach to prevention and control of diabetes was built around the healthcare system, and this is historical. So we've always had a heavy burden of infectious diseases, and diabetes, on the other hand, is not infectious. It's what we call a non-communicable disease. So by having higher levels of infectious diseases, the healthcare system was built around treating infectious diseases. consider disease like maybe malaria. I develop it maybe in the evening, I run to the hospital in the morning, I get treatment, and within a day or two I'm fine. Diabetes doesn't work that way. It's a chronic disease, which in Uganda we call lukomvuba, meaning that you will have it, we normally say, for the rest of your life. That we can always take that with a pinch of salt, because when it comes to diabetes prevention and control, there is some evidence that's coming up that actually with the right lifestyle, even people whose blood sugar has been rising can be reverted. And this is one of the things that we're able to demonstrate in our research. We're able to show, for example, that with just minimal tweaks at the healthcare system level, supplying glucometers, which are used to test glucose, training healthcare workers on standardized guidelines, and ensuring that the drugs are available. Actually, up to 50% of people who we would normally characterize as being at high risk of diabetes, we are able to revert back to normal levels. And that is quite something when it comes to the medical world, because this is one of the few studies that has actually tried to demonstrate the fact that you can actually revert the course beyond the normal. And how do we do that? When it comes to diabetes as a disease, the healthcare worker can only do so much. Most of the work is on the individual, so it's up to the individual to take their drugs. But beyond all that, it's up to the individual to actually take their life in their hands and decide that I'm going to beat this disease. And they do that by eating right, by exercising, by trying to reduce stress, taking on those activities like, in fact, exercise. Exercise is very good with stress reduction. And by doing all that, individuals actually are able to reduce their risk of diabetes and in some cases revert the course.
Let's talk about the Smart 2D project.
Yes, please.
What is it all about?
Yeah, so the Smart 2D project is a consortium. It involves about 5 countries, and those countries are both in Africa and Europe. So in Africa, it was Uganda. It is Uganda, actually, because the study is still ongoing at other sites. So the project is taking place in Uganda and South Africa. And then in Europe, it's taking place in Sweden, in Belgium, and in Finland. This project is aimed at finding innovative ways of preventing diabetes among those who don't have it, but at high risk, and also controlling it among those who have it. This project has 3 research sites. The Uganda research sites, for which I was the project coordinator, and then the South African site at the University of Western Cape, and then in Sweden it's Karolinska Institute. All 3 sites are conducting research that is aimed at trialing or testing community strategies among individuals to see whether these strategies can actually control the disease. The Uganda site has completed the data collection, and we are now analyzing that data, and we've already seen some interesting results. So our results have demonstrated that with the right interventions at the facility level, and these interventions are not really highly technological, just the normal things. You write treatment guidelines. At the moment, we don't have standardized treatment guidelines at health facilities for diabetes. So we're able to design simple treatment guidelines, train healthcare workers on the same. We are able to design guidelines on health education. How exactly should we approach education of patients on diabetes at the facilities? Traditionally, our health education has focused on malaria, diarrhea, and all these things, which are a big problem, but we've neglected diabetes. What we did was to actually come up with the messages that we think are key to guiding patients on the way to self-management. And then we trained healthcare workers on those guidelines, and they are able to administer these. And we also came up with patient registers, appointment cards, to ensure that we don't lose our patients along the way.
How many healthcare centers have you been able to interact with so far and train?
Yeah, so our study has been focused on 9 health facilities. And this was in Uganda and Mayuge districts. And we worked with the healthcare workers at these facilities. This way we are able to demonstrate that, because normally with research, sometimes we tend to sit in the labs and not to work with real-world setting. What we did with our study was to actually go to the facilities and institute these interventions, and then we are able to see the results that I've mentioned. Yeah, the results that we've seen are quite interesting because with those simple measures, we are actually able to demonstrate that you can revert the course of diabetes among those at high risk, at least by about 50%. So they revert to normal levels. You can actually control diabetes by 10%, among 10% of patients. And you can actually retain patients by about 30%.
And all this you've been able to realize in the 9 health centers?
Yes, in the 9 health centers over the period of about only 1 year.
Brilliant.
Yes, 1 year.
Now focusing on the people that are high risk when it comes to diabetes, what are they doing wrong? What should they be doing right? Because a number of could even be high risk right now and I don't even know.
Yeah.
Yes.
Yeah.
Yes. Are there telltale signs that maybe I could be bordering that line?
Unfortunately, when it comes to diabetes, you don't feel anything. So diabetes and other non-communicable diseases are really silent. So you have the problem and you don't know. And I wouldn't blame them so much when it comes to what are they doing wrong, because some of the problems actually is what we call structural, that the way our system is built does not enhance, for example, physical activity. Look at what the streets look like. You can't really ride a bicycle on those streets to work and be safe, so you stand the risk of being run down. However, individuals have the option of undertaking some of these activities at home, so you don't have to go to the gym, for example, to exercise.
Like Fit in 5?
Yeah. We have a segment where people exercise for 5 minutes.
Okay.
Yes.
Yeah.
Or perhaps doing the show while we stand. Would that even be better?
Could we try?
We could.
The director will murder us. Okay.
I know. So, if at all you choose to exercise, eat right. And when it comes to exercise, it has to be a little more than 5 minutes. Yeah, in fact, we talk about 150 minutes of moderate intensity physical activity.
How many times a week?
Should
you do 150?
About 5 times a week. The 150 is over the course of the week.
Okay.
But we're saying that you don't do it in one day. Do it over the course of the week, 5 days in a week.
Spread it out.
Yeah, spread it out. Eat a lot of fruits and vegetables. We have what we call the the healthy plate. So the healthy plate is divided into 3. So half of the plate should have fruits and vegetables. A quarter should have proteins like beans, meat, peas, and then the other quarter should have carbohydrates like potatoes, cassava. When we're talking to our patients, we normally tell them it should be just 1 fistful of carbohydrate, 1 fistful of beans, meat, and everything else, all combined into one, and then half fruits and vegetables. Yes.
But what type of fruits? There's also a bit, can I have pineapples? Can
yes,
I have bananas?
actually.
Natural sugars are good?
Yes, the greater the variety, the better. Yeah, so we talk about variety. Actually, one of our researchers was able to demonstrate in their work that the more variety of foods you eat, the lesser the risk.
Interesting.
Yeah, so variety comes into play at that level. Yeah.
When will this roll out? Already you've interacted and actually, been able to positively impact 9 healthcare centers.
Yeah.
When will this roll out to the rest of the healthcare centers across the country?
Yes, so we're in touch with the Minister of Health. Actually, the Minister of Health has been a good partner with us, because when we set out to do the study, we contacted them, and we've worked closely with the program manager of the non-communicable diseases program at the Ministry of Health, and the ministry has actually received our work very well, and they have promised to look into it. They have invited us to go and present bits and pieces of our work to them, and then hopefully they are going to co-opt some of those things. And we've also, of course, there's a lot of research going on, and we have different partnerships even at the School of Public Health. We have other researchers who are actually doing work on other non-communicable diseases, and we always try to do this hand in hand with the Ministry of Health. Yeah, so that they know what we're doing, and they can always advise us on what they think is practical.
All right.
Like when we are designing this study, there are things they told us not to do, because they said that even if it works, we won't be able to afford that. So we worked with only those interventions that they believe and we do that they can
affordable
co-opt.
and sustainable.
Yeah, exactly.
Wow, interesting conversation. So with regards to the same, as we come to a close, what should we be expecting from the Smart 2D projects in the near future?
Yes, so we did a dissemination workshop about 2 weeks ago. So we've disseminated. We're waiting for the data from South Africa and Sweden, who are still conducting the study. And then we should be able to actually give a collective message as Smart 2D. Our project was built around informing the different settings. In Uganda, we worked with a rural low-income setting in Uganda and Mayuge. In South Africa, they worked in the townships and settlements. And then in Sweden, they worked with refugees. And we worked along the premise of reciprocal learning. So we hope that by getting the feedback or the data from South Africa and Sweden, we should be able to pick bits and pieces of what they managed to achieve successfully and incorporate them into our own work here in Uganda.
Okay, interesting conversation. Thank you so much, Dr. Francis Xavier Kasuja from Makerere University School of Public Health. Now you know you can actually try and do your bit with regards to ensuring that you prevent, getting diabetes. If you're there, you now have the information on how to control it. Thanks to this particular project, at least we'll be seeing some milestones being covered by the public health centers in the country. That has been it, but the hashtag is Morning at 10 TV. Keep your views coming. We'll be sure to look at those. Thank you so much for coming in studios.
Thank you.
Right at this point, we want to tell you how traffic looks like. It's drizzled a bit, rained in some parts of the country, so I'm sure traffic is bumper to bumper. Stephen, are my assumptions correct?
Yes, Mala, right here at the Chabwe Road, near the heart of the city center, is where I'm coming to you from. And already, as you can see from this other side of Old Kampala, joining Rashidi Kamis Road as well as the Chabwe Road where I'm standing right now, it's already bumper to bumper traffic jam connecting to the other side of the Kampala Road. For you who is coming from that direction, just know that you will almost be spending like 20 minutes of your drive time between the Old Kampala police station as you connect to this Chabwe Road, joining the Kampala Road side. Depending on where you're heading to, if you're coming from the other side of Wandegea and using Gaddafi Road, I can only advise you for now that you use this side of Mpabana Road. The Mpabana Road is the one that connects you towards Seka Market through the Aga Khan Nursery and Primary School around the Gaddafi Road, connecting to this Seka side, and use this Mpabana Road. At least there is some traffic jam along Mpabana Road, but the good thing is you keep driving there as you connect to Seka Market and then join Chabwe Road. If you know you are coming from the other side of the heart of the city using either William Street through Benchwanuka Street, joining Bombo Road, just know that at least after crossing the Alua Park section, connecting to